afternoon. Am I audible? Hello, good afternoon. Am I audible?
Yes, Sharada, you're audible.
Yeah. Good afternoon to all. At the outset, I would like to thank the organizers for giving me this opportunity to speak on this crucial topic of performance of geriatric assessment in India, adaptation to our scenario. Before moving on to my talk proper, I'm sorry, disclaimer. The term older adult with cancer or older adult oncology is preferred these days over terms like geriatric and elderly. I've tried to replace and use the appropriate words throughout my presentation. However, forgive me if if these words do crop up. So the outline, I'm sorry, there is, okay. Outline of my talk would be what is a geriatric assessment, the need for geriatric assessment, and then I would be focusing on the components of geriatric assessment and the Indian scenario with explanation of the status of geriatric assessment in India, the barriers, and the future perspectives. So when it comes to guidelines, there is no shortage of guidelines when it comes to older adult oncology or geriatric oncology. We have NCCN, we have ASCO guidelines, we have the ESMO-SIOG module, we have the comprehensive geriatric assessment by the International Society of Geriatric Oncology. We have had journal series with JCO, Lancet Oncology, and the Indian journal Cancer Research Statistics and Treatment, which always has original articles on older adult oncology. So the big question in geriatric oncology is always whether to treat or not to treat. Is the patient fit or is he frail? So it is crucial to determine the functional age of the patient. And is the patient as old as he looks functionally, or is he actually biologically younger? So it is important to determine the functional age and maintain the functional age throughout the treatment. So whenever we see geriatric patient, I believe it reminds me of the last scene in Shakdev, where Shah Rukh Khan goes through complex internal battles within himself, whether the goalie should move to the right or to the left, or whether the goalie should remain in the center. So it is that kind of tough internal battles that we face when we usually see a geriatric oncology patient. So why is the treatment so difficult? This is because geriatric oncology per se is a heterogeneous, deals with a heterogeneous group of patients. So you may have a variety of patients coming to you with different issues, and there is always an increased risk of adverse events of treatment, especially financial and QOL issues. And these set of patients are usually not represented adequately in clinical trials. So here, as you can see the different text boxes, you might have different permutations and combinations of patients who may vary in their amount of in the all patient and cancer related factors. So there is the concept of something called as resilience. As you can see, the line on the top, the dotted blue line on the top represents the highly resilient older adult patient with cancer, where the stressor of cancer therapy does not actually produce any decrease in the functional status. Then you have the non-resilient and the resilient patients in whom the functional status may or may not be retained after cancer treatment. So with this introduction, I move on to what exactly is geriatric assessment. So geriatric assessment is a multi-dimensional interdisciplinary diagnostic process. Usually there is an oncologist, the geriatrician, pharmacist, and a social worker. Obviously, seeing this list, we always understand that this might not be feasible in India, where a smaller team might have to actually work on geriatric assessment, at least in the earlier stages of establishment of a geriatric oncology clinic. Basically, geriatric assessment will determine the medical, psychological, and functional capability of a frail older person. Not only determine, they have to develop a coordinated and integrated plan for treatment and long-term follow-up. It identifies problems that are not identified by routine patient history and clinical examination, and suggests tailored interventions for improvement of the patient. And finally, last but not the least, discuss the patient preferences and treatment goals. So how does geriatric assessment help? Does geriatric assessment actually help? Yes, geriatric assessment helps in identifying impairments, clarifying the patient priorities, predicting survival and toxicity. It helps to establish a pre-treatment baseline. And by developing tailored interventions, it might improve the patient vulnerabilities over time. Generally, on an average, the treatment plan may change in around 15 to 40% of patients, as this study has shown from India, where nearly 30% patients had a de-intensification of therapy with withholding of therapy in 10% of the patients. This is the international data where the treatment plan was modified in 40% of patients, with 2/3 of the patients having less intensive treatment, and more than 70% of the patients had geriatric assessment based interventions, which might not have been otherwise identified. So naturally, looking at all this, the question that comes to our mind is our clinical judgment not enough? So this has also been studied formally, where a poor correlation has been found between clinical judgment of frailty and objective assessment scales. In the Indian Geriatric Oncology Clinic, surprisingly, 98% of the patients had vulnerabilities in at least one geriatric domain. And in essence, you had only 2% of the patients who tested normal in all the geriatric domains. So in all our cancer assessment, we automatically assess the Eastern Cooperative Oncology Group performance status. So does that correlate with the comprehensive geriatric assessment? Unfortunately, no. The correlation is not perfect, though it may correlate with some abnormalities like function, falls, psychological and cognitive assessments. It poorly correlates with nutritional status, and most importantly, it has a poor correlation with chemotherapy toxicities. So what exactly is included in geriatric assessment? Screening and comprehensive geriatric assessment. Now, over the next few slides, I'll be going through a lot of tools or questionnaires that are well validated in Western population, and some of them are validated in Indian population also. I will not be explaining each questionnaire in detail. However, I will be going through what exactly is can be adapted to our situation. So screening tools, we have mainly 3: G8 or the Geriatric 8, the Vulnerable Adult Survey 13, and the Ftrsc. So the Geriatric 8 has 8 items, of which 7 are related to nutrition, and 1 item is related to the age of the patient. It takes less than 10 minutes to do this as per Western literature. Now, score of less than 14 is believed to be abnormal. If you see these questions, you can see that most of these can be asked in India also. Food intake, weight loss, mobility, some neuropsychological issues like dementia, depression, body mass index, taking medications, and the other one is comparison with the other people of the same age. So this looks overall doable in our setting. Next is the Ftrsc, which is very frequently used in the OPD setting. Again, this looks very simple. It is simple. It is just a score for each of these factors, where presence of cognitive impairment is scored 2. All the other factors are scored 1. This also looks very doable in India and is actually doable with the caregiver support, difficulty in walking, falls or transfer, any hospitalization in the last 3 months, and polypharmacy of more than 5 medications. So score greater than 1 is considered as risk factor. Now, this is the Vulnerable Adult Survey, which consists of 13 items. This is a self-administered question, which is validated in over 65 years of age. Here again, it again looks very doable in the Indian population, where stooping, crouching, kneeling. 10 pounds is nearly 5 kilos. Then you have reaching above the shoulder level, grasping small objects, quarter-of-mile walking, heavy or light household work, shopping, managing money. All this looks feasible in the Indian setting. Actually, these tools have been studied in India, where an abnormal G8 cutoff score of less than 12 seemed more appropriate in the older Indian adults with cancer. Now, the beauty of this cutoff is that 35%, there was a 35% reduction in the number of patients undergoing a complete geriatric assessment. So the ideal way to go about would be to use a screening tool, identify the patients who need a comprehensive geriatric assessment, and then choose the patients well for a comprehensive geriatric assessment. Again, though the fact that the Tata experience showed that 98% of the patients had actually comorbidities that had vulnerabilities in geriatric domains, we unfortunately we have to use some screening in our setting as of now, where there is limited access to comprehensive geriatric assessment. Most of us in the current setting where we are practicing, if a geriatric assessment, comprehensive or not, needs to be done, we might have to do it ourselves if there is no geriatric oncology setup. So I think that is about screening. So now coming to the comprehensive geriatric assessment. Now these are the most important domains that are assessed during a geriatric assessment. So we have the functional status. I will come to each of them in brief. We have comorbidities, we have cognition, mental health, nutrition, geriatric syndromes. I've highlighted polypharmacy because that is very important, and social support. There is also an additional domain of fatigue. So in addition to this, there is the chemotherapy toxicity, calculating life expectancy, and geriatric assessment based interventions. So how do you assess function? Function is usually assessed by the activities of daily living or instrumental activities of daily living. Now looking at these lists, again, feeding, continence, transferring, toileting, dressing, bathing seems to be well applicable to our population. Now, however, when it comes to instrumental activities of daily living, there are a few things which may be difficult to apply here. Now, using the telephone, there has been some controversy regarding use of telephone. There is some limited access to telephone in rural places where patients who are not familiar with using a telephone might find it difficult to answer this question. But however, with this booming mobile industry, I think now most patients are exposed to mobiles and even smartphones, even though they are old. That is something that has to be debated. Again, there are some gender-related issues in this IADL, where preparing food, housekeeping are believed to be more predominantly female, and it was doubted whether it was initially suggested that females be given a score from 8 and males be scored by 5. Anyway, I'm not going into that. Now, assessing the function and mobility, this is the timed up and go test. Now, I'm putting this specifically because there is an Indian study which has actually correlated this timed up and go test with the presence of comorbidities, impaired cognition, poor nutritional status, depression, and anxiety. And there is a lower overall survival for patients with the timed up and go of more than 12 seconds. Now, if you look at the instructions, it looks very simple. The only thing that we have to do extra is to mark a line that is 3 meters away. So the patient has to get up, walk 3 meters away, touch and come back and sit. So this seems very doable in our setting. And since it has a good correlation with other domains of geriatric assessment, this is a good tool that can be used in our clinical setting. Now, comorbidities, though I've put the Charlson Comorbidity Index and the CIRS questionnaire, this is something that we routinely do in our practice. So I'm not going into details. We always do ask for comorbidities, and it is necessary to emphasize in this thing that in this presentation that we not only have to identify comorbidities, we have to treat them, we have to modify the cancer treatment accordingly, and maybe our estimation of life expectancy may also differ based on the comorbidities. Now, I think comorbidities is something that we do routinely in our clinical practice. We could at least, even if we don't use a score, we could at least ask and document what are the comorbidities that the patient has. Coming to cognition, there are again multiple tools that have been suggested. Mini cog test, where the patient has to listen, repeat the terms and draw a clock. Many Indian patients might not be familiar with the clock phase, but I think literate patients should be able to draw a clock normally. Now, blessed orientation and memory concentration test, BOMC score. Again, this has the patient needing to identify what year, month, and it is. Now, in Indian patients, sometimes they know the Indian months. They may know that Dhanu, Rashi, or whatever it is of that day, but they might not actually realize whether it is January, February, or March if they are illiterate or if they are more familiar with the Indian dating system. So we can use the mini mental state examination, which has been translated into Hindi also. But and I think all the MD medicine graduates are quite familiar with this MMSC because we were required to do this as a part of the neurological examination, where this was the first step for higher mental functions. Now, Geodetic depression scale, this is a self-administered questionnaire taking around 5 to 10 minutes. Now, this again becomes difficult because many Indians are quite, there is a significant social taboo with the word psychiatry, or if you use terms like, shall I refer you to a psychiatrist? I've had patients and patient attenders vehemently refusing, no, doctor, my father is quite all right. He does not require any psychiatric assessment. They seem to take it as a personal insult if we actually refer them to a psychiatrist. So I'm not very sure how to apply this to our practice, but I think we could make it a practice to just ask the patient attenders whether the patient seems down, or whether the patient is in seems to be having any of these high risk symptoms. Another problem with these self-administered questionnaires is that Indian patients, I recently completed a questionnaire-based study where I found that many patients had just filled up the form not at all sincerely. Because though they were termed literate, they just knew to read, barely read. So they found it difficult to read. So instead of asking for help, they just filled one option and for each question, and just returned the form back to us. So I feel that when we give self-administered questionnaires, we have to be very careful and be quite sure that the patient is motivated and will give us correct responses. Now, this is the mini nutritional assessment. Nutritional assessment is a significant part of Geographic assessment. Again, if you look at the column on the right, where we can see that there is at least one serving of dairy products, meat, fish, or poultry every day. So I think this might be difficult. This question might be difficult when it comes to vegetarian Indian patients. Now, this is my favorite part of the Geriatric assessment, that is the chemotherapy toxicity. Usually the chemotherapy toxicity might be assessed by the CARG score or the CRASH score. The CARG score correlates for risk of grade 3 to 5 toxicity. There is a free online CARG calculator which is very easily accessible, and it does not ask any complicated question. All these questions can be answered during the first assessment itself, with 5 questions that are 5 variables that are based on Geriatric assessment. And this is very much doable in our clinical setting. And as has been elegantly shown by Tata Group, Vikas Oswal sir's team, where the CARG score was validated in Indian patients. So we don't have to worry that this score was not validated in Indian patients. It has been shown to be, the risk of toxicity is shown to increase with increasing risk score. The CRASH score looks a little more difficult to use, but there is an online calculator for the CRASH score also. But it requires that we have MMS and MNA, that is the mini nutritional assessment and the mental status examination, and LDH values, which might not be otherwise routinely checked in our patient. Now, coming to the life expectancy, again, we have the Lee-Schonberg index, or there is a site called eprognosis.com, which helps us to calculate the life expectancy. Now, the problem with life expectancy is it is a validated score when it comes to Western population, but this sample has not been taken from India. Now, coming to geriatric syndromes, we have syndromes like depression, constipation, failure to thrive, sarcopenia, and polypharmacy. So most of the geriatric syndromes are yes/no questions in the questionnaire. However, polypharmacy has been defined as 5 or more medications, and PIMs are potentially inappropriate medications which are preferably avoided in older persons. Now, there are again criteria and tools for assessment of polypharmacy and potentially inappropriate medications. Beers criteria, the stop tool and the start tool are all helpful when it comes to avoiding polypharmacy. But again, in India, I think polypharmacy is definitely important. And I think most of us, as a part of our clinical practice, do ask the patient, are you taking any medication for this thing? And we do make a note of whatever the patient is taking, usually as a part of our routine history taking. But I think polypharmacy, identifying polypharmacy is something more than that. In that we may have to coordinate with our primary care provider to actually see which of those medications are needed, and maybe we have to coordinate very well with the general medicine consult, with the physicians regarding the medications used. So in the Indian geriatric clinic, polypharmacy was present in 55% of the patients. And the other concern is the Ayurvedic and homeopathic medications, with which the interactions with our medications are not known clearly. So it is very difficult to convince patients to not take Ayurvedic medications, and many of them take it without informing us. So it becomes quite difficult for us to identify polypharmacy sometimes. Coming to geriatric assessment based interventions. Now, though this looks complicated, it basically involves whatever vulnerability we have identified in the geriatric assessment has to be addressed. So I think if we identify the vulnerabilities, all of us are quite capable of referring or addressing those abnormalities. As I mentioned, for IADL, they can take physical therapy or occupational therapy. Falls can be dealt with by fall prevention, discussion, education. Nutrition is something that I think we need to take care of with the dietitian's review or caregiver education. According to ASCO, what is the minimum? So looking at this minimum, I felt that most of the things are actually included in the minimum also. But let's just look at this list and see what we can do in our clinics. So I think CARG is doable. Life expectancy plus minus e-prognosis score can be used, but it's not validated, but it can be used. IADL can be very well asked for. Comorbidity assessment, yes, we do ask for it. Screening for falls, yes, it is just a question. We can ask, have you fallen? Did you have any falls in the last 6 months? Screening for depression, as I mentioned before, there are some issues with this geriatric depression scale, and asking this in directly to our patients might be a little difficult. Screening for cognitive impairment, we could use the MMSE. Again, malnutrition screening, I think again we can do it easily because all of us have a facility where the weight of the patient is checked quite easily. Though the patient might not know the pre-existing weight, we can ask them if they feel that they've lost weight, or we might not get the quantification of the weight loss. So in clinical practice, I think in India at least, it would be good to use a screening tool with a cutoff of less than 12 if G8 is used. And if a screening tool is found to be abnormal, maybe a full geriatric assessment can be done. So unfortunately, geriatric assessment has been proven to take quite some time in the Western setting and in the Indian setting. This 22 to 27 times minutes that has been documented is when part is already completed by the patient through self-administered questionnaires. In India, patients might require help to fill the questionnaire on their own. So you might have to have a social worker or somebody who will help to fill the self-administered questionnaires. Now, this is what I mentioned before with the commonly deranged geriatric assessment domains of comorbidities and polypharmacy in more than 50% of the patients, and other domains that have been impaired. Now, in 70% of the patients, there was an estimated risk of 50% of chance of at least 50% of developing grade 3 or higher toxicities. And most of the patients were unvaccinated. And according to this experience, a median of 50 minutes was taken for the physician administered part, excluding the time taken for self-administered questionnaires. So as expected, when a survey of Indian oncologists was conducted, though 99% provided care to geriatric patients, 44% were not aware of formal guidelines, and 70% reported assessing older patients using intuition or informal assessment only. So time, I think, is the crucial issue. But there has been an elegant study which was where a report was where it was reported that a nurse's salary for 1 hour might be actually cheaper than many other investigations that are done routinely for cancer. So I think it is about attitude and us realizing that it is important to do a geriatric assessment. So it has to be, the awareness has to come from within us also. So now coming to the appropriateness of these tools in India, most of this I've covered during when I showed the tools itself. However, a few other points. One is the definition of older adults. So though the definition is used as 60 or older, the Western tools are all for maybe older patients. So maybe an age adjustment should be applied for the tools when we apply it to India. So IADL, as I mentioned, in joint families, there might be the household chores might not be performed by the patients even before the cancer was diagnosed. So there is no point in asking them whether you perform household chores now that you're sick. So I think that becomes redundant. I've already gone through the issue of telephone use. Relocation for treatment is also a significant issue where many patients who have relocated for treatment might not do local shopping or might not be aware. Again, illiteracy is a significant problem for all the self-administered questionnaires and many of the cognition questionnaires. So I think that also has to be dealt with. And among Indians, there is a thin, low BMI, healthy body habitus also among many patients where the BMI might be actually lower than 21, but they may be healthy. So it might be difficult to quantify based on BMI. Anyway, weight loss quantification, as I mentioned before, might be difficult, and vegetarianism is also an issue. I already mentioned about the psychiatric taboos, and social issues in joint families might be different, where patients have good social support when they're in joint family system. Also the question on functional mobility, where it is asked whether the patient can move about in all weathers. It might not be appropriate because in India, the weather changes might not be very obvious in at least some parts of India. Now, when many of the older adults have nursing aides or maids who come and take care of them. So again, asking them whether you do the household chores on your own might not be appropriate. And one more big barrier I feel is the language diversity. Even if you manage to translate your questionnaire to one regional language, that would not be enough. Most of us, when we practice, I think we use minimum 3 languages in our clinical practice, I feel. So translating them into 3 languages and validating them becomes an issue. 3 for one consultant, obviously. Now, are there other Indian studies other than the Tata study? Yes, there is the Geriatric department of AIIMS is also quite active, where they detected that 75% had a functional impairment. And they have actually developed a shorter screening tool called Scope-C, where there are 13 questions with responses of 0 to 4 that is possible. It takes around 25 minutes to complete, and cutoff score of 66 or 64 was used, whereby they've made some recommendations based on this. So these were the domains that were assessed. Now, if you look at these domains, most of these are common domains when you look at the comprehensive geriatric assessment. So many of these questions are can be adapted to India and can be used in India quite well, as it has been validated in the Indian patients. But this still takes 25 minutes. So I think we will have to take some, we may have to use some more adjustment to make it a little shorter maybe. Because on an average, it has been found that oncologists in India or other low middle income countries see more patients per day. I think average oncology load in a clinic must be around 30 patients per day. And if 70% of them are geriatric, then again, I think 25 minutes per patient might be a little too much, in addition to the other things that we have to do. Now, so time restraints are the most common most common barrier that has been cited again in the survey. Lack of clinical staff is something else. So I feel in most of our practice centers, we have ourselves and we have somebody who will send the patient in for us. Beyond this, I think having support is a luxury. But one use that we can do is we can delegate the questionnaires and we can use allied subspecialties. So we have physiotherapy, dietitian, and other trainable allied specialty staff who are actually capable of being trained to administer the geriatric assessment questionnaires. So I feel that we should use some delegation and use allied specialties not only to give the questionnaires, but also for the interventional part of the geriatric assessment. And also for the lack of awareness, there could be online and online fellowship programs and education programs. And coming to the future perspectives, what can actually be done in India? We saw that the acceptance rate for geriatric oncology is quite low. And I have to admit it myself, as of now in my center, despite giving this talk, I do not have a dedicated geriatric oncology clinic, nor do I have a dedicated geriatric oncology assessment part. I do try on my own to assess whatever patient geriatric patient who comes to me with the minimum basic parts. But often I'm also found hard pressed for time for doing this assessment. So what can we do? Improve the DM medical oncology curriculum. We could have geriatric oncology long cases so that it becomes so much ingrained into our training that we do it automatically and effectively when we start practicing. Development of more geriatric clinics. Integration of tumor boards is also interesting. If the tumor board decision is to have a comprehensive geriatric assessment, I think there might be more compliance from our end. There is need for more Indian clinical trials and increased awareness. policy changes and institutional support for research. I think Dr. Swaratika will be talking further about the research perspectives in geriatric patients. The development of an Indian short elderly oncological assessment tool is on the way. And I think as far as possible, people should get trained, establish geriatric oncology clinics in their own centers, and then train further people in geriatric oncology assessments. Technology assisted, this is something that has been elegantly pointed out by Vanitha madam and team, that the increasing use of technology, we can try, if not the patient, at least the caregivers can help in doing technology assisted geriatric assessments. The patients can have smart watches or smartphones whereby the tools of geriatric assessment itself can be coordinated with the technology. Support group formation. Also, the GA interventions, the assessment interventions can be delegated to primary healthcare systems. I don't know how doable that is in our center, because most cancer centers do not have access to primary healthcare system. As a part of the tertiary healthcare system, we are quite away from the primary healthcare. But I think we could at least identify physicians who are interested in geriatric oncology and sort of develop a coordination with them, trying to develop a coordination and discuss with them regarding the geriatric oncology issues. So to conclude, I feel that geriatric assessment is feasible in the Indian settings. It is just that we have to be little adaptive and understand the importance of geriatric assessment. And I think we have to choose whatever tool we are comfortable with and use that tool well. So we start small with a few tools which we are comfortable with. At least if we do a screening now and then do part of the geriatric assessment, what we feel we could integrate into our settings, I think we should have a good beginning. So as I mentioned, there are multiple online resources. You could refer to any of these sites for all the tools, and many have online calculators also, whereby we could complete the tools online. Thank you so much for patient listening. Any questions from the...
Thank you, Sharada. I think you covered almost all aspects of geriatric care. And